Hello, good afternoon. Thank you for coming to this lecture. I'm going to speak about lung cancer, mostly non-small cell lung cancer and small cell lung cancer. I'll try to provide an update of the current advancements in lung cancer using radiation therapy and drug-based therapies. These are my disclosures. I work at City of Hope National Medical Center. I'm based in Irvine, Orange County, California. So as I said, I'm going to focus on locally advanced non-small cell lung cancer and its recent advances, as well as limited stage small cell lung cancer. So as you know, the latest advancements in non-small cell lung cancer have mostly come with the use of systemic therapy, either targeted therapy or immunotherapy, particularly anti-PD-L1 treatments. In our field, in radiotherapy, there's been many attempts to improve our outcome historically in the 80s up until now. So, for example, using higher doses of radiation therapy, using a concurrent versus sequential radiation therapy. And RTOG 9410 established that the use of concurrent chemoradiation therapy was better than sequential chemoradiation. That was the standard of care for many, many decades. Despite that, advances trying to improve upon those outcomes with addition of, for example, targeted therapy and dose-escalated radiation therapy have resulted in no improvement in our treatment outcomes until the most recent studies, the use of the Pacific study, the use of adding anti-PD-1 therapy in conjunction with chemoradiation as adjuvant therapy. So I'll start with a case. This is a patient of mine, 64-year-old man, never a smoker, initially diagnosed with stage 3A non-small cell lung cancer, T1B, N2, M0, multi-stage nodal disease, as you can see from the PET scan. Molecular markers was negative for any oncogenic drivers, such as EGFR or ALK. PD-L1 was less than 1%. So in this case, what are the options for treatments? Is it chemoradiation followed by observation, chemoradiation followed by durvalumab or anti-PD-1 therapy, induction chemoimmunotherapy followed by chemoradiation followed by durvalumab, chemoradiation followed by consolidated chemotherapy, or neoadjuvant chemoimmunotherapy followed by surgeries. So we'll talk more about this case, but in general, sort of what are the optimal treatments for a patient like this. This is from the latest ASCO guidelines for treatment algorithm for patients with unresectable stage 3 non-small cell lung cancer. They recommend that the treatment should include a platinum-based doublet chemotherapy, preferably cisplatin etoposide or carboplatin and paclitaxel. Alternatively, you could use other regimens. Radiation therapy should be a minimum of 60 gray. 70 gray could be used with careful selection to paying attention to toxicity related to the heart, lung, and esophagus. So here you can see from the algorithm, patients with good performance status, they are recommended to give concurrent chemotherapy with radiation. With no disease progression, patients get either consolidation immunotherapy, or most recently, if they have an EGFR mutation, they will get consolidation osimertinib. We'll talk about the data around this that led to this finding. Patients that are not good candidates for concurrent chemoradiation therapy could be treated with sequential chemotherapy followed by radiation, or patient with poor performance status, they would be potentially treated with radiation alone. Optionally, could be treated with hypofractionated radiation therapy with modest hypofractionation. So as we all know, radiation therapy is often combined with immunotherapy, and what are the potential benefits and detriments of using the combination? So we know that with immunotherapy and radiation therapy, radiation activates pathways such as STING that allows for immunopriming. Radiation therapy causes ablation of the cancer, release of tumor antigens, leading to antigen presentation and more effective in combination with immunotherapy. However, we also know that radiation therapy could be immunosuppressive. Radiation therapy activates T regulatory cells that lead to release of cytokines that are immunosuppressive, such as IL-10, TGF-beta, And so sort of the yin and yang of radiation therapy as far as its potential adjuvant to immunotherapy is not 100% clear. This is the Pacific study. I think many of you are aware of the study, but this study really truly defined the current standard of care. These patients were unresectable stage 3 patients who were treated with at least 2 cycles of platinum-based chemotherapy and then randomized in a 2-to-1 manner to up to 1 year of durvalumab immunotherapy versus placebo. The primary endpoints were progression-free survival, overall survival with a number of key secondary endpoints, including time to distant metastases, safety, etc. Here's a summary of the Pacific study. As I said, this is a phase 3 study comparing an anti-PD-1 antibody, durvalumab, as a consolidation for stage 3 patients. This is the most recent update that showed a median progression-free survival at randomization, that's 17 months, with durvalumab versus 5.6 months. The 1-year progression-free survival rate was 55.9% versus 35%. The 18 months PFS was also statistically significant, 44% versus 27%. So in summary, PFS was significantly longer with durvalumab versus standard placebo. Similarly, with 5-year survival, the outcome was still maintained that the use of consolidation immunotherapy led to improvement in overall survival. The 5-year survival rates was 42.9% with durvalumab versus 33.4% with placebo. Same thing with the improvement in PFS. So these updates show that there's robust and sustained overall survival benefit with use of durvalumab after chemoradiation therapy for stage 3 non-small cell lung cancer. Like all studies, the details are more important than the actual findings sometimes. So you can see here from the hazard ratios of different stratifications, most of the stratification variables showed a benefit in terms of the use of durvalumab, regardless of age, smoking status, stage 3 versus B, 3A versus 3B, tumor histology, although patients with adenocarcinoma did better than squamous cell carcinoma. And the response really was not indicative of whether they will respond to adjuvant durvalumab. But what's important is that only a third of the patient had PD-L1 testing, and many patients did not have EGFR mutation status known. But based on what we know, patients that are EGFR positive may not benefit. As you can see, the hazard ratio crosses 1. So in summary, EGFR mutation was only a small proportion of patients, but not all patients were known that to have that mutation. PD-L1 testing was not required. Also, PD-L1 testing was determined for the initial tumor specimen prior to chemoradiation. So it's unclear whether or not the status of PD-L1 staining after chemoradiation was different, would have been more predictive of response to immunotherapy. Also in Europe, they did an ad hoc studies of patients with PD-L1 expression cutoff of 1%, showing that those patients with only less than or equal to 1% PD-L1 staining did not significantly benefit from adjuvant immunotherapy. So in Europe, only the patients that have PD-L1 positivity were given this treatment. This is from the toxicity table from their publications. Again, the most common side effects for immunotherapy include cough, fatigue, shortness of breath, diarrhea. Most patients with or without immunotherapy had relatively low risk of pneumonitis, with grade 3 to 4 pneumonitis only approximately 3.4%. The most common adverse event that led to discontinuing immunotherapy was pneumonitis and radiation pneumonitis. But what about in the real world? You know, oftentimes in clinical trials, outcomes are better in the trial based on how they've standardized the treatment algorithm. This is a nice study of almost 1,400 patients from 11 countries in a real world setting. They took patients with stage 3 non-small cell lung cancer, then they follow them through the course of their outcomes up to 5 years, looking at their progression-free survival, overall survival, and then at 5 years as well. Key assessment points are PFS and overall survival. The median time that the patient was on durvalumab was almost 1 year, 11 months, and they have almost 2 years of follow-up as of this publication in 2023. This is their progression-free survival. I just pointed out that their median PFS was 21.7 months. That's actually better than the original Pacific study, which is reassuring that this outcome is translatable to the real-world outcomes. This is their subset analyses based on the PD-L1 status, disease stage, tumor type, and prior chemoradiation, CRT. Patients, again, with PD-L1 expression did better than those that had less than 1% expression by the median overall survival. Stage, not surprisingly, was clinically significant as well, with patients with lower stage having better outcome. Non-squamous histology, for example, adenocarcinoma did better than squamous, and prior CRT, concurrent CRT, was better than sequential chemoradiation. Toxicity, again, we want to know how the patients do in real life. Again, of this big subset of patients, the number of adverse events was not that different from the original Pacific study, where most patients had some evidence of pneumonitis, but only about 5%. Led to temporary interruption of immunotherapy, and about 10% of patients had permanent interruption of immunotherapy based on a risk of a pneumonitis. So overall, I think the toxicity profile was consistent with the original Pacific studies. So can we improve the outcome with more intensified use of immunotherapy? This was Pacific 2, a study ran by the company in non-US countries, because by this time, the adjuvant use of immunotherapy was standard of care. In this study, they randomized patients 2-to-1 after chemoradiation, they randomized 2-to-1 to concurrent chemoradiation with durvalumab versus placebo and CRT versus with adjuvant immunotherapy versus placebo. So even though the study was positive in the US, many countries did not have patients who had access to durvalumab, and this was a way for them to offer access to immunotherapy by offering them concurrently. So the question is, are we able to improve outcome by giving the immunotherapy earlier rather than at the advanced stage after chemoradiation? But unfortunately, if you look at the overall survival and PFS, there was no added benefit of giving immunotherapy. In fact, you saw a loss of benefit, because compared to no immunotherapy, the overall survival and PFS was not statistically different when you add immunotherapy concurrent with radiation therapy. So Pacific regimen remains the standard of care, and this was a relatively surprising finding, because we all felt that if you add immunotherapy with radiation, then perhaps you can improve the outcome further. Another unmet need is the question related to, I think, very relevant to countries in Asia, where a lot of patients have other mutations like EGFR, ALK, and other target mutations. So LAURA was a phase 3 trial assessing patients that have EGFR mutation stage 3, whether in comparison with chemoradiation, followed by adjuvant placebo versus adjuvant osimertinib, which is, as you know, a third-generation EGFR TKI. So what's the rationale for the study? Approximately 30% of patients with non-small cell lung cancer presented as stage 3, locally advanced. A third of those patients potentially have an EGFR mutation. Osimertinib is a very effective drug that's been shown to be beneficial in patients that had surgery, followed by adjuvant osimertinib, called the ADAURA study. Also in FLAURA, which is in patients with stage 4 metastatic EGFR positive non-small cell lung cancer, showed a benefit in terms of survival. And data from previous studies showed that potentially they could benefit from this combination versus the use of immunotherapy. Patients were randomized either they were getting concurrent chemoradiation versus sequential. 200 patients were then randomized 1-to-1 into placebo versus daily osimertinib indefinitely. And then it was an open label study. Patients were allowed to cross over if they progress on placebo to the osimertinib arm. And they looked at post-progression overall survival, et cetera. So this was presented at ASCO of last year, showing a dramatic benefit in patients to receive osimertinib indefinitely after chemoradiation versus placebo. In fact, the benefit at 2 years was 65% versus 13% for PFS. The median median progression-free survival is almost 40 months with OC versus 5.6 months. And this has become standard care in the US in the patients with stage 3 after treatment with chemoradiation. You can see here from the subgroup analyses, overall, almost all subgroups benefited from the adjuvant use of osimertinib, whether it's sex, age, race, stage, And then there was some differences in the type of EGFR mutation, but both types benefited. Concurrent versus sequential, most patients had concurrent chemoradiation versus sequential, and it was not significant whether or not the patient had complete, partial, or stable disease, whether or not osimertinib was beneficial to them. So what are the other ways we can improve upon in patients with stage 3? This is another study, Checkmate 73L, where they added concurrent nivolumab to chemoradiation, followed by a combination of dual checkpoint inhibition, ipilimumab and nivolumab, versus the standard care of Pacific, where it was concurrent chemoradiation followed by durvalumab. This study was run by Bristol Myers Squibb, and as of 2024, they closed the study because they did not meet its primary endpoint of progression-free survival at the interim analyses, and such that there was no better than the original Pacific regimens. So I guess the question is, why do many of these studies become negative when you combine immunotherapy with concurrent radiation therapy? We wrote an editorial hypothesizing that even though radiation can upregulate PD-L1, allowing for more benefit in terms of consolidated immunotherapy, on the other hand, radiation is very detrimental to T cells and immune cells. So potentially by giving a concurrent radiation, we're killing the T cells as they try to be upregulated into the tumor microenvironment. And I think some of the strategies that are upcoming, we're using hypofractionation, SBRT, may be a better approach by becoming less immunosuppressive, and we could extrapolate from our evidence from earlier stage using SABR or hypofractionation to leverage the possibility of benefit between immunotherapy and radiation therapy. But clearly, I think radiation effects are dependent on fractionation, schedule, sequencing. It's not so straightforward. By adding more immunotherapy early on, we're going to get a better outcome. What are some of the other unmet needs? So these are just some questions that we have. Outcomes for unresectable stage 3 non-small cell lung cancer still remain suboptimal because after chemoradiation, the 5-year survival rate is less than 50%. A third of the patient will progress at the primary tumor sites, therefore local control is still suboptimal. And the use of Pacific regimen does not appear to improve local regional control in that manner. The primary tumor is still the most common site of non-metastatic recurrence, suggesting better approaches to optimize local control. Local failure may drive distant metastases. Some of the other strategies that we're using to improve these outcomes, including adding novel agents. So this is the COAST study, a phase 2 study of 189 patients with 3 arms, using chemoradiation followed by durva plus another novel anti-immunotherapy regimen, monalizumab versus durvalumab plus oleclumab. And both of these arms look promising in terms of the standard, which is durvalumab, in terms of progression-free survival and overall survival. You can see the benefit here in median PFS and overall survival. And so these molecules have moved on to phase 3 studies that are ongoing. But for radiation therapy, I alluded to the fact that we might be able to improve upon our outcome using SABR approaches. Here's, as you know, this is a study a few years ago looking at SABR versus conventional radiation for stage 1 lung cancer, showing benefit of SABR. This is from MD Anderson, where we show that the combination of SBRT plus immunotherapy for some patients with stage 1 or patients with isolated lung parenchymal recurrence benefited from addition of nivolumab versus just SABR alone in terms of PFS. Other groups have looked at use of SBRT to the primary tumor and conventional chemoradiation for the lymph nodes to improve upon that outcome. So this was a phase 2 study recently published in Lancet, looking at SABR for the primary, mediastinal chemoradiation, and they're showing good regional control, distant control rates, and very low toxicity, low rates of pneumonitis, and promising local control with only one patient of this small cohort having a local failure. The median survival for this well-selected patient was almost 50 months. Here's a representation from NRG of this strategy using SBRT for the primary, chemoradiation for the lymph nodes, looking at the volume of the lung that received 10, 20, and 40 gray. Using this strategy, you are able to reduce the amount of normal lung tissue getting 20 gray and 40 gray. So maybe also a safety strategy using dose escalated SABR for the primary and then conventional treatment for the lymph nodes. This has moved on in the North America with NRG LU008 study randomizing patients to either standard of care chemoradiation versus SBRT to the primary chemoradiation to the mediastinum, followed by maintenance immunotherapy. The regimen for SBRT are conventional 54 grade 3, 50 grade 4, or 50 grade 5 fractions. Radiation then is to follow with IMRT to the lymph nodes with concurrent chemotherapy. It's meant to be a pragmatic study allowing various regimens to be given in this manner. We also did a study when I was at UCLA looking at the use of hypofractionation for stage 3. In this study, all patients have 40 grade that delivered in 10 fractions, followed by adaptive SBRT boost based on PET, the residual metabolic activity disease. And then we dose escalated the boost to 25 grade 5, 30 grade 5 versus up to 35 grade 5 for a total of 75 grade over 15 fractions with concurrent chemotherapy. We were able to show that this was a fairly safe regimen. Local control was excellent, particularly those patients that have dose-escalated treatments. Overall survival was, this data was pre-immunotherapy era, so the outcomes were more comparable to RTOG 0617, but nevertheless, we saw no evidence of grade 3 toxicity in the intermediate dose cohort, 60 grade delivered in 15 fractions. Other studies are ongoing, are looking at, again, novel agents in combination with chemoradiation. This is a Merck study looking at the use of anti-TIGIT, another immunotherapy regimen with concurrent immunotherapy pembrolizumab with concurrent chemoradiation versus the standard Pacific regimen. Again, these are some of the other ongoing studies in combination with either concurrent or sequential therapies. I mentioned some of the drugs that are studied, monalizumab, oleclumab, that looks promising, and the use of PARP inhibitor, et cetera, for stage 3 non-small cell lung cancer. So, I mean, I think we all know that stage 3 lung cancer is a very heterogeneous group of patients. Looking at particularly stage 3A, you can have a large primary with no negativity versus a medium-sized primary with N1 disease versus a small primary with N2 disease. These patients potentially can be very different in terms of prognostic outcomes versus a standard stage 3B patient. In North America, the guidelines suggest that pathological staging is very important to determine what kind of treatment they would get, and also, which patients are considered unresectable versus resectable stage 3 non-small cell lung cancer. Furthermore, this additional guidelines suggest the paradigm for use of surgery versus concurrent chemoradiation for stage 3 patients. Historically, stage 3 patients get surgery if they have no negative disease or patients with single-station N2 disease. But the paradigm is shifting with a lot of perioperative chemoimmunotherapy studies that have shown positive results. When we looked at the Pacific study and looking at patients with N2 stage versus non-N2 stage, stage 3A, the outcomes are very similar. For example, in here on A versus B, both cohorts of patients benefit from the Pacific regimen of adding durvalumab. In fact, you can say that those with stage 3A node positivity actually seems to do a little better with immunotherapy than patients that do not have N2 disease. Similarly, AEGEAN was a study using perioperative chemoimmunotherapy followed by immunotherapy. They also show that the benefit was consistent across all subtypes and were similar in patients with single-station versus multi-station N2 disease. So the surgeons and oncologists would argue that the paradigm have shifted. Multi-station N2 disease, some of them could be a candidate for surgery, and therefore, as radiation oncologists, we need to come up with better treatments to capture patients and show the benefit of chemoradiation versus surgery in some of these studies. So again, here with single-station versus multi-station N2 disease, the hazard ratio using this regimen is very similar, suggesting that N2 multi-station patients could be surgical candidates. Recently, this question has become very, very controversial. Again, which patients should have surgery versus chemoradiation? This is an NCDB study of large number of patients who either had surgery versus chemoradiation, and they were followed for outcome in this cohort. half the patient had surgery, half the patient had CRT followed by immunotherapy, and they looked at the outcomes. But if you, again, these studies are not perfect, they're not well balanced, and I would argue that surgical patients were more fit. This is their performance status. Surgical patients were more commonly operated at academic center versus community, whereas radiation patients were treated mostly more in the community. Histology-wise, there were more adenocarcinoma in the surgical cohort. They do better, and tumor location was slightly also different. In the patients who underwent surgery, it's interesting that still many of those patients had radiation therapy. Only 1/3 of the patients did not get radiation therapy. So it's not really a fair comparison because those patients got surgery, they also had radiation therapy. Those patients had radiation therapy never had surgery. But not surprisingly, based on this analysis, patients who had perioperative chemoimmunotherapy versus chemoradiation did better. Those patients in the subgroup analyses, again, showing that surgical patients did better than those that had non-surgical treatments. But retrospective analyses are always limited by selection biases, so it's important to make this argument at your tumor board when oncologists or surgeons discuss studies like this that are non-randomized. So here's a summary of the current paradigm for stage 3 non-small cell lung cancer. Non-surgical patients now get either chemoradiotherapy followed immunotherapy. If they're operable, they're getting perioperative or preoperative chemoimmunotherapy followed by surgery. But it's interesting now that patients have two options, either chemoimmunotherapy followed by surgery versus chemoradiation followed by immunotherapy. And again, it's hard to compare apples and oranges as far as their outcome based on randomized studies. There is an ongoing study in North America called the MTD Bridge, trying to address some of these uncertainties. So the idea is that patients who are stage 3 but borderline operable will get 2 cycles of immunotherapy and chemotherapy, and then there will be a discussion at a tumor board to determine if they're operable. The non-operable patient will get chemoradiation therapy followed by immunotherapy. The operable patient will get 2 more cycles of immunotherapy and chemo followed by surgery. So this is not a randomized study, but at least address the question of which are the best patients to offer surgical treatments with immunotherapy. In the last 20 minutes, I'll move on to small cell lung cancer and talk about some of the recent studies for small cell lung cancer, particularly for limited stage. For early limited stage small cell lung cancer, that's about, I would say, 5 to 10% of the patients. The standard of care is still mediastinal staging, followed by either surgery, lobectomy, or conventional radiation chemotherapy versus SABR, followed by adjuvant chemotherapy. This is a very small cohort of patients, again, maybe 5 to 10% of the patients. The role of radiation therapy is well established for small cell lung cancer. This was the original study from Pinon from New England Journal of Medicine in 1992, showing that combination of chemoradiation therapy was better than chemotherapy over a course of number of studies that were looked at through this meta-analysis. The first randomized studies that proved the benefit of radiation therapy was RTRG, or intergroup 0096, Percy study, that randomized patients to 45 gray and 45 gray and 30 fractions BID versus 45 gray and once a day fractionation, showing 5-year survival benefit with the BID regimen, and however, with higher rates of radiation esophagitis. Other studies look at twice-a-day radiation versus once-a-day hypofractionation. This is a European study from Norwegians, looking at BID, again, standard BID versus 42 gray and 15 fractions, showing that there was similar response rate for BID with slightly better CR rates in the patients that got BID, but similar progression-free survival and no difference in overall survival, though numerically BID seems to do a little better than once-a-day hypofractionation. More recent study looking at once a day to higher dose versus BID include this study from the UK, the Converse study, phase 3 study, with the premise that twice a day is the standard of care, with higher dose maybe superior to, again, BID treatments when you do dose escalation. 547 patients were randomized, 80% of the patients had PCI, median follow-up was 45 months, no elective nodal radiation was provided. Outcome for this study showed that the overall survival rates was 30 months versus 25 months for BID versus once a day. However, the hazard ratio crossed 1 and the p-value was not significant. 2-year survival rates was slightly higher numerically for BID, but again, not statistically significant. 5-year survival was very similar again, no difference in grade 3 toxicity. So actually much less esophagitis when you use IMRT and also when you don't cover the elective nodal basin. Conclusion, BID was no better than once a day. Therefore, BID is still standard of care. Similarly, for RTOG 0538, patients were randomized to 45-grade BID versus different regimens of once-a-day regimen. Eventually, it's a 2-arm study of 70-grade once a day versus 45-grade BID. Endpoints of overall survival, and there was no difference in their overall survival rates in either of the arm. Median survival, again, was very similar. 2-year survival similar. 5-year survival similar. However, there's a recent study, again, from the Norwegian group that compared BID to 45-grade versus 60-grade BID over 4 weeks. Dose-escalated regimen with PCI offered as well. It was 170 patients randomized 1-to-1, and these were the patients. Very few people were withdrawn based on ineligibility. This study did show overall survival benefit in those patients that got 60-grade delivered BID over 4 weeks, 37.2 months versus 22 months. It was well balanced, pretty high rates of treatment completion, similar rates of esophagitis and pneumonitis, which is a little surprising given that you would think that those that got 60-grade BID would have higher rates of toxicity. But this is also still a phase 2 study, so it's difficult to understand this is practice changing, especially in the era of immunotherapy. Here's a table of all the studies I presented. Although it's not fair to comparison across era, I would only point out that in this most recent study, the standard arm 45-grade BID seems to have underperformed relative to the most recent CONVERT and CalGB study, showing a median survival of almost 30 months versus 23. So this difference may be exaggerated between the BID 60-grade versus 45-grade BID. This is a nice astral guideline about small cell lung cancer, comparing treatment regimens of twice a day versus once a day chemotherapy, the sequence, the timing. I encourage you to look at this paper as a refresher for the current standard of care. We did a practice pattern study at UCLA a number of years ago, looking at what is the most common regimen, and most people in this study deliver radiation once a day, almost 3/4. The reason for once a day was because of convenience for the patient, convenience for the staff and the clinic, and that once a day was more tolerable for patients. These are the different dose regimens for once a day versus BID. For once a day, most patients got 60-grade, although some patients got higher doses. For BID, I would say majority were given 45-grade deliver twice a day over 3 weeks. What about immunotherapy for small cell lung cancer, limited stage? This was presented at the most recent Astral this past fall. NRG 005, the PI is Kristen Higgins. Patients with limited stage were randomized 1-to-1 into either 45-grade or 66-grade once a day with concurrent chemotherapy versus concurrent chemotherapy plus concurrent atezolizumab, anti-PD-L1 therapy beginning at cycle 2 of chemotherapy. Patients also got concurrent atezolizumab after chemoradiation in the experimental arm. Unfortunately, this study was negative in terms of survival, overall survival, PFS, disease-free survival, and local failure rate. They're virtually a negative study all across the board. Patient characteristics were very similar between the two arms for stage and the type of chemotherapy and regimen. About half the patients, just over half the patients, did not get PCI, and about half the patients or less got BID versus daily radiation therapy schedules. However, at the same time, this study called Adriatic was also being undertaken. This was a 730 patients international study randomizing patients after standard chemoradiation into placebo versus durvalumab for 3 years versus a third arm with dual checkpoint inhibition. These two arms were reported for overall survival and PFS. And in this study, those patients who got adjuvant durvalumab had significantly improved overall survival relative to standard care chemoradiation therapy, with median overall survival of 55.9 months versus 33, so a difference of 20 months. And so this has now become the standard of care for small cell lung cancer with the use of adjuvant durvalumab after chemoradiation. Again, another example why, as you can see in small cell lung cancer, those that got concurrent atezolizumab did not benefit, but those that got adjuvant durvalumab did get a survival benefit. This is the tornado plot for toxicity. The most common adverse event was pneumonitis, but high-grade pneumonitis was very similar between durvalumab and placebo. The other side effects include what we already know about immunotherapy, that they decrease appetite, causes cough, and has fatigue. And this was the discontinuous rate, again, very, very low, 8% versus 3%. And the high-grade toxicity was 3% versus 2.6%. Here are some of the key ongoing trials for small cell lung cancer with the use of concurrent durvalumab. This is another trial using a different anti-PD-1 therapy, and a third trial using both immunotherapy and a PARP inhibitor called Keylink 013. Moving on to the role of PCI in this new era. This is a summary of the studies that showed a benefit or lack of benefit with PCI. Initial studies showed a benefit of PCI, about 5% overall survival benefit, but many of those patients had no prior brain imaging. For extensive stage, however, there was conflicting results, with the European study showing a 1-year survival benefit, again, no prior brain imaging. The Japanese study showing no benefit with brain MRI for staging. So most patients are not offered PCI with extensive stage small cell lung cancer in the US. There's an ongoing study to answer this question for limited stage and extensive stage called the Maverick study. Patients are randomized into either to PCI or no PCI, looking at overall survival and other key secondary endpoints. MRI staging is required. Radiation therapy is recommended at time of brain metastases if they develop develop brain metastases. There are a few studies looking at the use of hippocampal sparing PCI. One study called the Premier study showed a benefit in terms of neurocognitive function using hippocampal sparing PCI versus none, and no difference in oncological outcomes with hippocampal sparing approaches. So in conclusion, integration of immunotherapy and targeted therapy has significantly improved the outcomes in unresectable stage 3 non-small cell lung cancer, which means that it's more and more important for us to know the molecular profile of the patient prior to starting chemoradiation. Integration of neoadjuvant and perioperative immunotherapy also has improved the outcome in resectable stage 3 patients who are off of surgery. I know that each country practices different patterns, but I think in America, in the US, we significantly shifted a lot of our patients to getting surgery given the beneficial outcomes of perioperative chemoimmunotherapy. The current controversy for small cell lung cancer in terms of the use of consolidated immunotherapy. And lastly, I would say that it's unclear which are the optimal patients that should get chemoradiation for stage 3 versus, again, perioperative chemoimmunotherapy followed by surgery. That's my last slide. Oh, I should say this is sort of where I practice. So City Hope is based in Duarte in Los Angeles. But we have expanded to Orange County, which is a county south of LA County. And we opened this facility there in 2022 in this outpatient building, 200,000 square feet, with radiation therapy occupying half of the floor. We have 3 vaults and HDR suite. And then we're currently building an inpatient hospital, which is this, that will open in December of this year, 6 stories for all cancer patients, 75 beds. And then recently we purchased this entire lot for 55 acres. So in our expansion, we'll continue to offer care for our Orange County patients as our second academic campus for City Hope. These are some of our team and the technology. We have MR-Linac, we have Ethos Adaptive Platform. I welcome anyone who's visiting Southern California to come visit us at either City Hope in Duarte or in Irvine. Thank you for your attention. I'm happy to take any questions, comments. No comments? Oh, you have a question? Oh.
Your presentations. I have one question for the PCI. In your slide, you maybe sure that now is a trial to prove. So how do you think about in your clinical contact patients for
PCI?
The other small lung cancer patients? Do you promote PCI for patients?
Yeah. So typically, this is a very good question. Thank you. So the question is, do I offer PCI for limited stage or extensive stage in the era of immunotherapy? I think for extensive stage, I don't particularly promote it or discuss it in those terms based on the controversy I showed. But for limited stage, I still offer it. And so I have patients that were treated with PCI with immunotherapy. So what we do is we would finish the chemoradiation and then wait about 2 weeks, do the MRI brain, do the PCI 2 weeks, and then they would get adjuvant immunotherapy at the end of the PCI, after the PCI. And that's because I think in the Adriatic study, half the patient were offered PCI. Whether you have PCI or not, you benefited, but we don't know the additional benefit of PCI currently. So I still think it's standard to offer PCI for limited stage, even with immunotherapy.
How do you think about the ideal dose for the PCI? Is 30 grade temperature or 30 grade 15 fractions?
Yeah, I usually use a little less. What's the dose for PCI? I usually use 25 gray in 10 fractions. And I would try to do hippocampal sparing. I've done hippocampal sparing with that, and also memantine to help reduce the long-term toxicity for neurocognitive toxicity. If you think of, they're living longer, right? They're if they get immunotherapy, they're benefiting. So it's even more important if we offer PCI to reduce the neurocognitive damage from PCI. So I do whatever I can to reduce that. Thank you for your question. All right, thank you.